Hello, I'm Nancy Kuntz, a child neurologist in Chicago. I'm professor of Pediatrics and Neurology at Northwestern Feinberg School of Medicine, and would like to talk to you today about genetic counseling for spinal muscular atrophy. I need to make the disclaimer that I am not a geneticist, but I do believe very strongly that there's a strong place for genetic counseling by a genetic counselor or geneticist as part of a multidisciplinary, comprehensive team for treatment of spinal muscular atrophy. As we know, it is an autosomal recessive disorder. It's a progressive disorder. The natural history shows that no one makes any additional motor gains after the clinical diagnosis of a spinal muscular atrophy. But we now live in an era where the good news is that there is treatment available, and the treatment appears to be effective the earlier it is given. I think this makes sense. Some of the early neurophysiologic studies showed that motor unit number estimates declined prior to clinical onset when children were monitored on a weekly basis when they were known to have SMA at birth. So we really have a lot of reasons why we want to give the treatment very, very early. The educational role that genetic counselors can play once the diagnosis is made through newborn screening or through clinical diagnosis of spinal muscular atrophy is incredibly important. The incidence of SMA carriers varies in different ethnic populations, but in general it's somewhere between 1 in 40 to 1 in 100. So the incidence of live births of babies with SMA is 1 in 10,000, or right around that area. The common form of SMA is caused by deletion of the SMN1 gene, which is on the 5th chromosome. A person survives perfectly well with one copy of SMN1, therefore SMN1 carriers are asymptomatic. And that's why it tends to be a surprise to parents when a child is born with SMA, because it's not something that has been in the family for the most part. And again, to have a very healthy looking newborn where clinicians are predicting progression to a very severe degree of weakness and death is a very difficult scenario for parents to absorb at the same time that they're celebrating the birth of this beautiful baby. So the role of counseling by the entire neuromuscular team, but in particular the counseling that can be given by genetics, is incredibly important in educating families about the natural history of untreated SMA and the potential for it to recur in other children. We have a graphic here that gives us a picture of autosomal recessive inheritance. Again, if you have two carriers, each of them have one copy, which is enough for them to be perfectly healthy and asymptomatic. But they will randomly, with each conception, give one of their sets of chromosome 5 to the new child. So you can see that sometimes with a 1 in 4 chance in the pregnancy, both of them will get healthy chromosome 5s and the child will be unaffected. Also, 1 in 4 chance with each pregnancy, the child will get the affected or absent copy of SMN1 and be an individual without SMN1 and therefore an individual who has SMA. 2 of the 4, or 50% of the time, the child will be a carrier because they'll get one copy from one parent or the other. And what's difficult for some families to absorb immediately is that this isn't a global percentage. This is the percentage with each pregnancy. So clearly, although they consider it very unwanted and unfair, there are individual families where the carrier parents have had children with clinical SMA 3 times in a row. Again, counseling parents is very important and very complex. It also involves giving parents information about potential for future pregnancies in ways where they can either predict or affect whether the child would be affected by spinal muscular atrophy through methods such as pre-implantation genetic diagnosis with in vitro fertilization. It's also very important to counsel the siblings so that they're aware of the potential for this to be something they may pass down to their children, depending on their partner and whether the individual that they have children with is also a carrier of SMA or not. The American College of Obstetrics and Gynecology now has SMA as a recommended screening for individuals who are undergoing preconceptional counseling by their gynecologists or obstetricians. And generally, the approach they take is to screen the woman. If the woman is a carrier for SMA, they would screen the partner. And if the partner is not a carrier, then there's no concern and they don't take the issue any further with respect to spinal muscular atrophy. However, if the partner is also a carrier, then the genetic counseling and planning for pregnancies can go into play. Most SMA runs true to phenotype within a family, meaning that the degree of severity is relatively much the same in different people who have it. However, there can be crossovers, so that some individuals within one family might have infantile onset and another have a child with SMA, or another child of the same sibship might be a sitter. There might be individuals who are walkers who have a sibling on rare occasion who does not have clinical onset until adult years. This is another reason why it's very, very important that siblings be counseled. Newborn screening has been recommended by the Secretary of the Health and Human Services of the federal government in the United States. I think that it will take a number of years for all of the states to respond to the recommendation by the Secretary to include SMA on the newborn screening panel. There are a number of states, about 12 states at the time of this filming, that have a newborn screening in place, and another dozen or more that have active plans in place whereby newborn screening will likely come into play within the next year or so, and then probably the rest of the states will take a few more years. Screening these infants is done by looking for the presence or absence of SMN1. So therefore, 95 to 98% of individuals destined to develop SMA will be identified with newborn screening, but that's not the entire population of SMA. There will be that small fragment that will have to be diagnosed clinically. A question arises about when treatment should begin. When infants have been identified with spinal muscular atrophy, because we know that there are motor neurons that are being lost and that are deteriorating prior to clinical onset of symptoms, and because it has been demonstrated in all of the clinical treatment trials to date with the FDA-approved agents that the earlier the treatment is begun, the more robust the response to the treatment. The recommendation by a team of experienced individuals to develop some consensus about this has happened twice. The first time this happened, about a year ago, a recommendation was made to treat all individuals with 3 or fewer copies of SMN2. At that time, a year ago, there wasn't as much experience with treatment with all of the agents, and the ability to differentiate the number of SMN2 copies when they were 4 or greater was not as precise. Therefore, consensus couldn't be reached about what to do with 4 copies of SMN2. However, this has been revisited, and at the time of this filming, there's a new consensus recommendation contained in a letter to the editor of the Journal of Neuromuscular Disorders, recommending that with 2 through 4 copies of SMN2, that individuals be treated immediately. Part of this, again, relates to the fact that at present, the use of the gene replacement has only been approved up to the age of 2, and that the incidence of inability to treat with that gene replacement because of development of antibodies against the AAV9 virus does increase with age, so that may not be a treatment that's available later in life. There are a number of approved treatments at the time of this filming. One of them is a targeted ASO administered intrathecally, and the other is a gene replacement therapy that is approved for individuals under 2 and given intravenously. Another that is an oral small molecule that does exon skipping has been submitted to the FDA. There are a number of places that clinicians can go to get additional information. Cure SMA is a family support organization, as well as Muscular Dystrophy Association, and they both have very active websites. There are also web pages available through the National Society of Genetic Counselors and American Board of Genetic Counselors. In summary, I would like to emphasize that spinal muscular atrophy is a genetically determined progressive disorder. It has been a perfect candidate for newborn screening. The participation with geneticists and genetic counselors in educating families and disciplines in medicine about spinal muscular atrophy has been great. Newborn screening to identify pre-symptomatic cases is currently approved by the Secretary of the Health and Human Services and is on the recommended uniform screening panel. A number of states have pilots or active screening in place, and there are a number of, and the rest of the states should either be shortly or in longer term busy with the process of adding spinal muscular atrophy to their newborn screen.